So my story I start with today, a shy young girl, not unlike the one pictured here, sat in bed, quiet and tachypnic. Her mother, not understanding what was going on due to a language barrier, looked frightened in the corner. The child gazed up at me with big brown eyes, questioning my N95 mask, gown, and gloves. This was the scene when I met my first patient with tuberculosis, not in Asia, nor at Latin America or Africa, but here at Stony Brook. As I began taking my history, I came to learn that she and her mother had traveled from a small town in Mexico to Long Island over the course of several days. During their travels, there were times when they were separated or detained in small rooms with hundreds of other people, all of whom were coughing, vomiting, and in some cases, scratching. They then arrived on eastern Long Island and explored, taking in their surroundings, and she looked forward to her new life. She too started coughing. We'll get back to more of what happened to her at the end, but for now, it is important to understand that this journey that I'm describing is one of the many. There is a border crisis, and the number of unaccompanied children is increasing. They are sent alone by parents who remain in their country heartbroken and hoping that their children survive the journey and discover a new life. This has been a hot topic as of late, and the media has taken a particular interest. Many literary pieces have been written describing the journey to the US, not unlike what my patient described. But what I find most interesting is that sources state that there has been a shift in whom they see coming. Previously, it was males and older teenagers. Now it is children less than 12 and an equal division between girls and boys. These children come often without vaccine records, many with poor health conditions, and we have to take notice. There are many patients in our population today that have this, that are from these countries. Actually, 1 in every 5 people in Suffolk County is an immigrant. Immigrants from El Salvador are the largest population, followed by India, Italy, and the Dominican Republic. I'd like to see a show of hands if you take care of patients from these areas. Just look around for a second. These children are not just at the border, but in our backyards, and we have to take notice. They are often coming without vaccine records, many from poor health conditions. Although we don't know much about them, we do know that what they bring are some diseases that we have not seen for many years. TB is not just an international issue, but a national one and a local one. Although one Ebola patient caused quite a stir in New York City, there are hundreds of people in Suffolk County alone living with TB. Just think about that, and think about the fact that children present with vague symptoms. Often, they don't present with the classic fever, night sweats, or cough. We need to think about this again. We are going to have to delve deeper into our patients' environments. Think about where their family is from, where their parents are born, in order to get a better sense of their risk factors. This may not be easy, as many of them have family and friends who are undocumented, and we have to be sensitive to this issue. We have to remember that the health of this girl and many others may be on the line. It is important to diagnose TB and treat it, as this prevents transmission. But we are pediatricians, so why just treat disease when we can prevent it? We can and we should. It is important to diagnose and treat TB and understand it as a continuum. You get exposed, you become infected, and you get disease. In fact, children have a much higher rate of progressing from latent tuberculosis infection, or LTBI, to active disease, as many as 40%. This makes the diagnosis of LTBI quintessential in decreasing the transmissibility. What testing can we do? Previously, we, as healthcare providers, were only equipped with the tuberculin skin test, or TST. This test, although useful, has some difficulties, and it's always been a question from our health communities as to how to interpret this test, especially in light of a previous BCG vaccine. What was developed was a blood test, a new test called the quantiferon gold in-tube assay. This, like the TST, looks at the body's immune response to the TB antigen. But unlike the TST, the QFT is not influenced by a previous BCG vaccine. So why don't we use the QFT in everyone? Well, for children older than 5 years old, it is recommended in the Red Book as an alternative to the TST. Previously, it was thought that children less than 5 do not mount a robust immune response, making the interpretation of their test difficult. My research looked at who might benefit most from this test in our population, and though the numbers were small, we did find that all of the children under 5 did make a robust immune response. Therefore, the interpretation of their test was valid. When thinking of LTBI, think QFT. So back to my patient, what ended up happening? Her father, still en route from Mexico, several days behind her and her mother, arrived as she was being admitted to the ICU with extensive pulmonary disease and pleural effusions. She was subsequently diagnosed with active TB and started on a regimen of medications that she took daily. So I urge you to think about the patients in your practices, in your schools, and in your neighborhoods, and think about TB. We have to remember that the population whom we serve and the community where we live is constantly changing. And with that, we must change as well to diagnose and treat conditions that we may not have had to.